I'm a board-certified plastic surgeon. I'm trained in the University of Pittsburgh, which used to have one of the largest programs in minimally invasive surgery and laparoscopic Roux-en-Y gastric bypass. As a result, we've done over 2,000 post-bariatric plastic surgery procedures, and that's where I started my interest. All the patients that I'm going to show you have given their consent to the use of their pictures, and they are virtually all post-bariatric patients, with a few exceptions, and I will tell you. So that's me. I worked for about 4 years with Dennis Herwoods. He's a pioneer of total body lift. So how do you choose your plastic surgeon? First of all, you want to make sure that your plastic surgeon is board certified, because there are a lot of other people who are doing plastic surgery and are not board certified in plastic surgery. You want to go to somebody, in my opinion, who specializes in post-bariatric body contouring. That means they're up to date, that means they follow the field, that means they have experience. You want to look at pictures. This is the most important part. From multiple angles, not one side only. You want to look at the scar quality and symmetry, scar placement, numbers. Have they just done one of these? Do they do one a year, or do they do 5 a month? And then you want to look at the artistic expression of your surgeon. Don't take anything for granted. So today I'm going to be talking about advances that we have made within the past 4 years in post-bariatric plastic surgery. A number of techniques have been developed, and I'm going to try to summarize some of those and show you a number of pictures. For many plastic surgeons, body contouring is a reconstructive surgery. That means it's a functional procedure. It doesn't have to look good, but it has to remove the pannus. It has to make you more comfortable. I think that's absolutely incorrect. You can really apply a lot of the aesthetic principles that we learn as plastic surgeons and try to recreate a feminine figure with curves, an hourglass look, or a masculine figure as appropriate. An understanding of the and appreciation of what happens after weight loss is absolutely necessary. So where do I start? Typically, I really start by looking at the patients pre-operatively. I want to make sure that they have medical clearance from their primary care physician. Your safety is my #1 goal. I'm going to do a comprehensive lab studies. I'm going to look at your nutrition. We've shown that nutrition is extremely important for the healing process. And I'm going to start you on nutritional supplements, and I'm going to try to reduce your risks of having long surgery. Last year, I published this paper in Plastic and Reconstructive Surgery, which is our premier journal, telling other plastic surgeons what every plastic surgeon should really know about nutritional deficiency of post-bariatric patients. It's well known, it's well documented, but we need to pay attention to it, because a lot of our patients come with nutritional deficiencies of their protein, vitamin B12, folate, thiamine, vitamin A, iron, and selenium. And essentially, the nutritional deficiencies are going to be dependent on your procedure. If you have a lap band, you're going to be less deficient than if you have had a Roux-en-Y gastric bypass, or if you had a biliary diversion that most people don't. In this country, 80% of our patients get Roux-en-Y gastric bypass, and 20% are getting lap band. This is going to be a growing population. But having said that, even the lap band patients are going to be nutritionally deficient, meaning that if you operate on them and you impose injury, trauma, stress on them, these subclinical levels of vitamins are going to be even further reduced. And in this slide, we just go through the percentage of deficiencies of post-bariatric patients. 25% of patients are deficient in protein, 37 B12, 35 folate, 18% thiamine, not that important in the healing process, but the rest of them are. Vitamin A, extremely important for healing, and the majority of patients are deficient. Vitamin C, very important, 35%. Iron, you all know about. Zinc, you all know about. And selenium is very important in your defense mechanisms. So having completed the first review, then I looked at the effect of nutritional supplementation in our patients. And essentially, this follow-up paper that was published last December in Plastic and Reconstructive Surgery really tries to teach other plastic surgeons that protein is important in wound healing and your defense mechanism because of this. Vitamin C, vitamin A, B12, folate, iron, zinc, selenium. So everything that a post-bariatric patient is going to be deficient in is important for your proper healing and for your defense mechanisms. Therefore, we have to pay real attention to this. So before you start surgery, you have to understand that you're operating on patients who do not absorb proteins and vitamins, and therefore, since then, I put all my patients on a surgical supplement that was essentially formulated for the weight loss patients to optimize their nutrition and get them up to par before we operate on them. And I start everyone for about a month on this product, then I will operate on them, and they will continue on this till they are healed. And I can tell you that in a recent analysis of my data, which was just sent to another journal for publication, I can tell you that this strategy has reduced my complication rates with regard to healing substantially, and almost to the level of a non-bariatric patient. I'm going to miss the facial rejuvenation. I think we want to mainly talk about bodies today. So what happens after weight loss? Typically, and I tell this to all my patients, this is your surgery. You can have one procedure or 15 or 20 procedures, and we're going to talk about 15 procedures right now. But typically, most patients come with arm laxity. It can be rather severe at times. They get hollowing of their armpit. They get ptosis or sagging of their armpit. They get deflation of the breast. Some become very, very asymmetrical, the breast. Abdominal laxity. Some patients also have upper abdominal laxity in this region. And then they get laxity of their thighs. And that laxity of the thigh can be both in a vertical dimension and a horizontal dimension, or what we call a circumferential dimension. These things are important because the techniques that we have developed for each one of these is different. So the way I do the surgery is to stage it into 2 portions, sometimes 3. Usually I do a 6-hour surgery, and I do the extended arm lift. Then I do some form of upper body lift appropriately, some form of breast reshaping with some liposuction. Then about 3 months later, the patients will have a lower body contouring, which is typically a thigh lift, and I will be talking about the spiral thigh lift, which we've pioneered. Some form of buttock reshaping. It's a buttock lift, buttock augmentation, and buttock reduction. A lower body lift with circumferential tummy tuck, Munsplasty, which is elevation of the groin area, and more liposuction. So this is what it is. On the back, this is your upper body lift, the lower body lift with the buttock lift, some form of thigh lift. On the front, finishing the tummy tuck, finishing the breast. It's important to realize that many of our current plastic surgery techniques are not optimal for post-bariatric patients. This is because the post-bariatric skin has been internally damaged, and when you take a standard plastic surgery technique and apply it to a post-bariatric patient, the results do not last as long. You cannot rely on the skin to shape and hold tissue in place. You really have to modify the tissue underneath the skin and just drape the skin over it.